Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elseygood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose Naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. Today's show sponsor, Care First Specialty Pharmacy. They are leading compounders of LDN and other custom treatments servicing patients in over 18 states coast to coast. They are widely accredited to provide you with the highest quality demanded by the industry and the expert service you expect. To learn more, call 844-822-7379 or visit cfspharmacy.com. Today I'm joined by Dr. Jackie Silkey, who's from just north of Salt Lake City in Utah. She's a functional medicine practitioner. Thank you for joining us, Jackie.
Thank you for having me.
Could you tell us, how long have you been prescribing LDN?
I've been prescribing LDN for about 5 years now.
And what conditions so far have you treated?
It's quite a wide range. I started out using LDN for autoimmune disorders, including Hashimoto's, lupus, other autoimmune disorders, and then now have kind of branched out into other areas and using LDN for other applications as well.
And what kind of results have you seen so far?
I've seen very good results. I always use LDN as part of a program where I'm addressing more of the root causes of what's going on and putting a comprehensive program, both nutritional, exercise, stress reduction, those type programs into place, as well as doing quite a bit of functional medicine testing. And then I bring LDN as an extra anti-inflammatory, as an extra treatment arm in most of my patients that I see and that are successful with implementing the base therapy.
Have you seen any negative side effects?
Yes. When patients first start LDN, sometimes patients will complain of vivid dreams or difficulty sleeping, those sort of common complaints. I'll either move them to either morning dosing, or I'll just, depending on how significant the symptoms are, I'll dial back on the dosage, or just tell them to go ahead and push on through, and that I find that it improves easily within a week.
Have you any people that you have treated who have had marvelous results? Do you have any case studies you could quote?
Most of my patients actually come to me to get a comprehensive program put into place, and then I actually don't see them routinely. They go back to their primary care physician once I'm able to get them improving, in the right direction. Mm-hmm. And so I don't have patients that are coming in monthly for checkups or checking in with me. So most of my patients will go back to their primary care physician once I feel like that they have plateaued on their healing with me, and have put into place, all of the aspects of healing that I find to be important.
Well, that's good, isn't it? So when a patient comes to you, you look at everything, their lifestyle, their diet, exercise, supplements, all this kind of thing, to try to get them to have a healthy lifestyle as well as treating the disease. Is that right?
Oh, most definitely. Most definitely.
Mm-hmm.
Yeah, in fact, a lot of times I try not to even look at the disease per se. I try and look more at the patient and say, why is this disease happening in the first place, and see what we can do as far as reinforcing them foundationally. And that's where I think LDN really plays a significant role, is to reinforce people foundationally, just like we do with nutritional aspects, exercise aspects, stress reduction aspects. Mm-hmm. all of this just to reinforce not only a nice environment for healing to take place, but also to prevent relapse.
Mm-hmm. Certainly understand that. And with a diet, what would you say is the best diet? We're always being asked this for people with autoimmune diseases.
Well, it truly depends upon the person, in my opinion. But first of all, I don't even like the word diet. There's so many negative connotations associated with it, and so I try and use nutritional plan, because I really want people to think about this being a nutritional plan, one that they don't come on and off of. So a diet, we always think of, I'm going to go on a diet and then I'm going to come off of the diet. And those things tend to be, somewhat more extreme. And so when I set up a nutritional plan, let's say for somebody with autoimmune disorders, depending on how significant what they've tried. There's some people that have come to me and have read every book and have tried, multiple nutritional plans and have had limited success with them. I don't go back and try and recreate those. I just learn from what they've had work and what they haven't had work well in the past. And then sometimes I'll do some functional medicine testing, some food sensitivity testing to dive deeper into that person's, metabolism of foods and their sensitivities and what their blood is doing when they eat certain foods. And that way I can kind of make a more personalized approach.
Yes. So are you a fan of vitamin D?
Oh, yes. We get a lot of sunshine in the summer, but I would say still the majority of patients that I test, and I do test everyone, the majority of patients that I test are low. And that may be an absorption issue from the GI tract. They're not absorbing it well. A lot of people don't know about vitamin D and that it's a fat-soluble vitamin and that you have to take it with a fat, otherwise you won't absorb it. And then there's some people that I don't think absorb their fats very well to begin with, and so they can have absorption issues. But I try and address all of those things, both in testing vitamin D levels, but then also taking a look at the GI tract and how well they're absorbing their vitamins.
But I would have to say, both my husband and myself, after listening to Dr. Tom O'Brien at the conference last year, we both stuck to the diet religiously, and I have been a diabetic type 2, and I was diet controlled for 4 years, and then I was on metformin, and I was told a few months ago, after being on the diet, say 6 months or so, that my sugar levels, when I had a blood test, showed they were pre-diabetic. And I was told that I could stop taking the metformin. So I'm thinking, if you're going to take the medication off me, what happens if they go up and I don't know and I have kidney problems? I was really panicking.
Right.
And they said, don't worry, we will take your blood again. And it showed that I was at serious risk of becoming a diabetic, but I was pre-diabetic and I didn't need to take the metformin. I've been assured and I've seen the results and I'm not worried about it, and I'm sure if I keep my diet as it is. But apparently once you've been diagnosed as a diabetic, they can't remove that from your records. So I'm now a diabetic in remission. So I'm really pleased about that, One less drug, yay,
Yes.
Am I going to have kidney problems? I hope not. But
well, I think that there's a lot of people that they can say that they are diabetics in remission as well, or diabetic in the making, one or the other.
Yeah.
So I think that, nutritional plans play a significant role, as well as exercise plans, and then implementing those exercise plans. And And then stress, obviously, stress is going to play a significant role.
If we just briefly talk about exercise.
Mm-hmm.
Now, one of the questions that we're always being asked, sick people can appreciate the fact that they should be exercising. People with, say, MS or ME, who suffer with severe fatigue, where any exercise, just moving, showering, is too much for them and they spend a lot of their time in bed. What
Mm-hmm.
can people do to try and exercise when they are that fatigued? What is your suggestion?
Well, you're absolutely right. I want to make sure that your listeners know that, we always talk about implementing exercise programs and then make people feel guilty for not implementing exercise programs. But there's some people that can actually be quite detrimental for. And if you do an exercise program and you're recovering for 2 days because you did too much, then obviously you have to build up your base before you're ever able to really do a formal exercise program. And so you really have to spend quite a bit of time working with the patient and talking with the patient about what they've done in the past, what was too much for them in the past, and seeing if you can dial in to what it is that their body needs. Because you take the same person with MS, and then you take, the person down the street with MS, they're going to have two very different exercise tolerances, and they're going to have two very different levels of benefit from doing any sort of formal exercise program. So you have to make it, in my opinion, very individualized, and that's where I find that it can be very difficult and can make people worse initially if people, if physicians or physical therapists or nurses or anyone are not listening to the person about what's been too much for them in the past and, starting low and going very slow.
Mm. So you learn to become fit enough to start to exercise, basically, very slowly and gradually, and not to give up and feel, that you're not achieving anything by baby steps. You do get there. It just takes a while, doesn't it?
That's exactly right. And everybody has a very different starting point. And so it doesn't really matter where your starting point is. It's only that you start there and that you move forward from there.
And I think it helps to keep a diary of what you can do and try and improve on that. And if you've only managed to do an extra 5 steps in a week, at the end of the month, you may have done 20 steps or something like that. It's all just very, very slowly and gradual. And then once you become fit enough, you can then, as you were saying, do a plan where you're exercising more, but you won't fatigue yourself too much by doing too much too soon.
You're absolutely right, and I think that's where pedometers, really play a significant role is in measuring steps, and there's a lot of things that people can do in their homes, just depending on where they are. Other things, to take more pressure off of the joints is to sign up for a program that's actually done in the water, taking some of the pressure off of the joints themselves. So if somebody tells me that they had quite a bit of soreness and joint pain, well, there's supplements that you can take before then. There's hydration that you can do before then. But there's also ways in which, if their joints are quite uncomfortable, that you can do exercise in the water. Even some gentle movements and walking within the water itself can take the pressure off of the joints enough to where you can slowly build from there. And there's actually a treadmill that's available, and that it's almost like it's built into a shower. And certain physical therapy places will have it, and where you can get in there and you can just very slowly walk on the treadmill, but in water, just to take some pressure off. Those are just some examples of different things that I'll have people do.
I'll make you smile. I went to a class to do Aqua therapy, and I was in my 50s, and I turn up and I was the baby. They were people who were 70 and 80. I was the youngster. It really made me smile. They were all so kind to me. So, and you wore a band round your middle, so you floated like a cork. So you could do exercises with your arms and your legs. There was no strain on anything, and you just bobbed. And it was difficult. It was really, really difficult. So yes. I was saying, I don't think I'm going to be able to do an hour. So the lady said, well, that's fine. We'll just do it gradually. I could only do 20 minutes.
Well, for some people, it's even just going to the facility, changing into a swimsuit, getting into the water, getting out of the water, and going back home wipes them out completely. It just depends on where people start. If people are quite ill, and then you obviously cannot start with a formal exercise program. You really have to work with other mechanisms that we have in place.
I couldn't walk when I got out of the water. Suddenly, because you're weightless in the water, and suddenly all the weight was on my legs, and it's like, whoa, I can't do this. I went home and went to bed, and I couldn't get out of bed and move without really severe problems until Thursday. So I did too much, but I didn't realise.
Yes.
It just seemed so easy, but my legs just, it was unbelievable. We will just go to a break, and we'll be back in just a moment. Today's show sponsor, Care First Specialty Pharmacy. They are leading compounders of LDN and other custom treatments, servicing patients in over 18 states coast to coast. They are widely accredited to provide you with the highest quality demanded by the industry and the expert service you expect. To learn more, call 844-822-7379 or visit cfspharmacy.com. Okay, welcome back. But stress, that's another thing we've never talked about so far on the radio show. What do we do when we're stressed, and being maybe defining stress versus depressed? I mean, when you have a chronic condition, if you're really ill, a lot of things become a problem to you mentally.
Yes. Well, I think that, when we talk about, it's really important for me to teach patients that when we're talking about implementing a stress reduction plan, is that it's not in the moment necessarily to relieve stress. It's about implementing a plan. It's like a nutritional plan. It's not like you implement a nutritional plan that day and you lose 10 pounds that same day or gain 10 pounds of muscle that same day. It takes time for you to see the fruits of your labor. But by implementing a stress reduction plan, you're putting more resilience into people's lives and into their body to be able to be more resilient with relapses, or more resilient with a major stressor that comes along, a car accident, anything that's going to be a big stress in somebody's life. And then being able to tease out stress reduction versus depression, I believe you said. Yes. Stress versus depressed. They tend to, and a lot of people go hand in hand. And that's where these comprehensive programs, including low-dose naltrexone, really helps people with mental health issues and with depression. Now, did they have a formal diagnosis of depression, maybe or maybe not, but still low-dose naltrexone by reducing inflammatory factors within the brain is able to help most people that are dealing with a chronic illness, because a chronic illness, by definition, is depressing to the body. It's stressful for the body. It's, it's living in a body that's inflamed. And living with a brain that's inflamed is very difficult.
We'll get to some questions and answers.
Yeah, that sounds good.
We have Marie, and she says she has a 7-year-old who was diagnosed with Crohn's 4 months ago. And she would like to ask, are other children taking LDN with success? And when would she expect to see improvements? And what would the improvements be besides better sleep? Would it assist with pain and quality of life? She was hoping that he would have more energy and be able to go through a normal day at school.
Yes, absolutely. Well, we were talking earlier about, patients that I have on LDN and my success stories. And, a lot of times I won't see them routinely, but one of the success stories that I have and that I still speak with this patient often is with a Crohn's disease patient. So Crohn's disease is, quite a bit of inflammation within the gut. So people that are dealing with a fire brewing inside their body, whether it be in their gut or their brain or their blood or wherever, it's going to fatigue them. It's going to decrease their energy levels. It's initially it might make somebody more agitated, but initially, as we know with adrenal insufficiency and, know about chronic illness, what initially fires somebody up and makes them hypermetabolic then slows them down later in the disease process. So what I tell people what to expect is variable. I put patients on low-dose naltrexone, and we watch. We take a look. We dial them up. I do tend to increase their doses slowly and watch for their most predominant symptom. For example, in the patient that I was referring to earlier, one of the hallmark symptoms that she would have was diarrhea. And so she would be having 8 or 9 loose bowel movements per day when she was in an active Crohn's flare. She also had some abdominal pain. And so once we were able to start her on low-dose naltrexone and then dial up her dosing, and actually we ended up doing something a little bit different in her. We ended up doing twice a day smaller doses instead of once a day larger doses. So you have to keep reassessing. But I will tell you that for some people, the response is dramatic, but and swift. But just because somebody does not have a swift or dramatic response doesn't mean that they aren't going to have a response either later or that it be kind of this slow uptick. So I would say that what I would tell the mother is that you're absolutely doing the right thing. See what the symptoms that are most predominant at the beginning of starting low-dose naltrexone, and then always stay in contact with whoever's prescribing it so they can help guide you on the correct dosage, the correct frequency, and know that there's going to be points and times. Crohn's is a great example. We were talking about stress earlier. Here's my patient was a student, and every time finals would come around, she would have a flare. And so knowing this, we knew how to put into place a stress reduction program that really dialed up a week or two before she started studying for all of her finals. And preparing earlier for her test, so there was less last-minute stuff. So we were able to, figure out what her relapse risk factors were, and then specifically guide that around. My plan, we ended up not needing the plan, but my plan was also going to think about going towards a higher dose 2 weeks before those stressful events. But we ended up not needing it. She was able to keep the progress that she had made throughout the rest of the semester into final examinations by just preparing earlier and knowing what she needed to do would affect what her final result was. So I don't know if I've given any specific, time frame. I will tell you it varies from person to person. But I would definitely take a look at the symptoms that your son is having. And that energy, in my opinion, energy usually comes around quicker in kids, but it tends to lag behind the other symptoms, their GI symptoms. So if he's having quite a bit of abdominal pain, might lag behind. Improvement upon the abdominal pain might come first, then energy might come after that. Imagine that the fire that is brewing inside the person's body is sucking them dry of energy. Well, you have to first turn off the propane to the fire, and then you have to extinguish the fire, and then with time, then that energy will then come back. There's really very few side effects, and the only time that it really plays a significant role is if I tell people about, if they have to have surgery or if they accidentally fall out of the tree and break their arm and they have to go on pain medicine, any of those sort of things where you're going to be stopping the LDN for a period of time or trying to use non-narcotic pain medications, which would be even a better choice. So do I feel that LDN is safe in children? Yes. And even in pregnancy, I have a couple of patients that are pregnant and that stopped LDN during their pregnancy and resumed it after they delivered the baby while they're breastfeeding. And I personally don't even think that there's any reason why anybody needs to stop it during pregnancy, but there's no studies that have looked at LDN in pregnant women because there's no studies that have looked at other medications in women, but we use them in people that are addicted to opiates. We'll use high-dose naltrexone and sustained-release naltrexone because the risk to the baby is much greater than the potential risk at high-dose naltrexone. And so low-dose naltrexone is an immediate-release naltrexone compounded formula that can be used in children and in young women.
I think many of the listeners will have heard Dr. Phil Boyle using it in his fertility clinics where they use LDN to get pregnant during pregnancy and during breastfeeding. He did a very good presentation for the conference last year, and it showed that babies born were of a better weight, had less need for antibiotics. Apparently some babies need antibiotics for chest infections and the like, and they were more contented than babies that weren't on LDN. And I thought that has to be good if you've got a baby that cries all the time.
Right.
So in his experience, LDN has been really good, and he did a small study. I'll have to send you the link to it, which was very interesting. Very interesting indeed. Okay, we have another question here from Lucy, and it's with atopic dermatitis. And I know that you do a lot of skin conditions in your practice. Now, I don't know if I'm pronouncing this drug correctly, but she says, please can you tell me if I can take LDN while on cyclozapine?
Cyclosporine?
It could be.
Yeah, cyclosporine.
Okay.
Yeah, sorry. In the U.S., I don't know if it's spelled differently in the U.K., but in the U.S., cyclosporine is spelled with a CY.
Okay.
It doesn't matter if that's what it is, cyclosporine. Yeah. Is it for lupus? Is that what you said, or chronic dermatitis?
Atopic dermatitis.
Oh, atopic dermatitis. Well, cyclosporine is a common traditional Western medicine drug that's used for autoimmune. So it's going to, decrease somebody's immune system reaction to themselves. So the thought is that, that autoimmune disorders are really yourself, attacking oneself. The whole idea of that, without looking at their foundational, a lot of times what I find is foundationally, people with autoimmune disorders, really their immune system is woefully inadequate for foundational reasons instead of hyperactive, if that makes sense. Mm-hmm. So people on cyclosporine can take this low-dose naltrexone, and it does not have any effect on cyclosporin or cyclosporin related conditions. Now, cyclosporin levels are normally checked for somebody who's had like a transplant, who try and keep their levels at a certain parameter. And I would say initially when starting any new medication or any new supplement, because everybody puts things through different detoxification pathways in our liver differently, I tell everyone that is taking, for transplant reasons, to have their levels checked after starting any new medication or any new supplement, because everybody's going to react a little bit differently. So would it potentially affect their levels? Possibly, but not usually.
Mm-hmm. Okay. And we have another one about atopic eczema and steroid.
Eczema?
Yes, and steroid treatment. And this lady has been using it for 30 years. And she says, my skin is very inflamed and I'm in a bad way. I have no quality of life, and my dermatologist is about to put me on what the drug we've just been talking about, and she's been off topical steroids for 18 months. And do you think LDN would help me?
As part of a comprehensive program, absolutely. I mean, I find with eczema, earlier we were talking about vitamin D and vitamin D absorption. Mm-hmm. I find that part of a comprehensive program, LDN plays a significant role in all of the autoimmune disorders that affect skin, that affect brain, that affect the GI tract. So I try not to treat a disease with a drug or a supplement. I try and treat the person who is having symptoms associated with the disease and look for what their rate-limiting step is. So, there's some people that, like I said, are not absorbing their fats well. They're not digesting. They've got some digestive enzyme insufficiency. They've got some, maybe some small intestinal bacterial overgrowth symptoms. They've got a lot of gas and indigestion, fatty stools, things like that. Well, that person, I'm going to, think about reasons for the eczema is just being a symptom of the problem. And by far and away, I find that things like eczema, psoriasis, all of these things tend to be more of a symptom of the problem. Instead of me worrying about labeling people with what their disease is, I say this is a symptom of the problem, and we're going to follow the symptom as we address, your insufficiencies as we find them. And that's where functional medicine testing, I believe, plays a significant role.
Mm-hmm. And by the time you've got the body working correctly, do you find a lot of the symptoms resolve anyway?
Oh yeah. Yes. That's when you know you've, and there can be several things that you uncover that may not be directly related. Let's just take eczema. It might not be directly related to their eczema, but yet play a very significant health benefit if you can address those things as well.
Mm-hmm.
So, but yes, I mean, anytime I'm seeing anybody with anything from acne all the way to psoriasis, I'm definitely treating internal,
mm-hmm.
Parameters instead of just treating, okay, is your acne better? I'm following many different things.
Mm-hmm.
But I think it makes it nice because with the skin, it makes it nice because you have an external way of evaluating how well your treatment is going. You just look at your leg and you say, yes, the treatment seems to be doing much better.
Mm-hmm.
And people do that with depression. People do that with, getting pregnant. You were talking about infertility treatment. I mean, that's the obviously the goal. Mm-hmm. And obviously the goal is to improve the eczema to where it's completely asymptomatic. But I don't find that putting topical treatments and putting, people on cyclosporin to be that helpful in getting down to the root cause. In fact, I think it just masks the symptoms. I mean, I have people come in all the time that, are on steroids or cyclosporin or other autoimmune medications. Humira is big here in the United States. Mm-hmm. And it just masks the symptoms, even if it controls the initial disease or the initial symptom that you were trying to control. Your body just has a way of showing it in some other area.
And what's the downside on using steroid creams long term over years?
Well, first of all, it changes the quality of the skin and what you're using it on, and second of all, you absorb some of that the steroids through the skin. So, not only are you making the skin, you're interrupting the barrier protection of the skin. Are you making it less of a good, barrier to mm-hmm. disease and to infection and all the rest? But you're also, delivering, depending on, if you're just using a small amount of steroid on one area, but there's sometimes some patients are having to put steroid creams on multiple areas of their body. And so that ends up being a fairly large dose of steroids. Some of that is going to get delivered systemically as well as just on the skin. So the problem with steroid creams is that they can thin the skin, and so we use thickness of the skin as a measure of health. So think about somebody's face. Think about an older woman's face versus a younger woman's face. Part of that aging process is a thinning of the skin. Mm-hmm. And so it therefore can't withstand pressures as well.
We will just go to a break and we'll be back in just a moment. Today's show sponsor, Care First Specialty Pharmacy. They are leading compounders of LDN and other custom treatments servicing patients in over 18 states coast to coast. They are widely accredited to provide you with the highest quality demanded by the industry and the expert service you expect. To learn more, call 844-822-7379 or visit cfspharmacy.com. Welcome back. Another thing I wanted to ask you, there's a lot of buzz going around at the moment about detoxing teas that you can have to flush out all the build-up that you have in your bowels. Are they a good
mm-hmm.
idea?
Well, I think that when we talk about detoxification, we talk about trying to find out, first of all, what you're detoxifying from, trying to get down to kind of a root cause. If it's, just general toxins that we're exposed to, then I think, ramping up your own detoxification pathways is the best way to do it. And pooping every day is an absolute mandatory in my clinic. Everybody that comes in, whether they're coming in for eczema or, people seek me out for low-dose naltrexone or for, functional medicine. That's one thing that I always talk to them about is how often they're having a bowel movement. And, so to work on detoxification when you haven't worked on proper bowel function is not going to work. It's, you're going to do one flush of a tea, and they might feel better for a day or two, and then they're going to go back to their regular bowel habits. And so,
sorry.
No. So it's just it's something that when, it's like anything else. Doing it once might be enlightening, but you want it to be something that they implement from now on. It's not a diet that they go on and off of. It's something that is going to stick with them and that it be a life-changing.
Okay, out of interest, how would you make yourself go every day?
Bowel movement?
Yes.
Oh, well, it depends on where I feel like the people are deficient in. So if they're deficient in water intake, if I feel like that they're magnesium deficient, which I would tell you that the majority of us are, even our soil in which we grow our vegetables are magnesium deficient. People tend to be very deficient on vegetables in general. So I try and calculate, I try and get an idea of how much fiber people are taking in during the day and what sort of bowel irritations they've had in the past. So treating somebody with irritable bowel syndrome, they've had multiple episodes of small intestinal bacterial overgrowth, and it's a very different process than treating somebody who comes in and just says, I have chronic constipation, but I don't have any abdominal pain. So you have to treat them very, very different. But somebody who's not having any abdominal pain, not having any abdominal symptoms, then I usually start with magnesium and ramp up their magnesium dosing and see if I can't, either test them to find out on a cellular level what their magnesium levels are, or see if what sort of improvement we get from ramping up their magnesium, but ramping up also fiber intake, water intake.
Mm-hmm. So keep flushing and eating those vegetables.
Yeah. Yeah.
Okay.
I love magnesium too. Magnesium is great, and it's great to help people sleep better. It's helpful with nighttime leg cramps. It's helpful with bowel movements. It's helpful with blood pressure, slight blood pressure elevations.
Well, it sounds a good one to take, doesn't it? And does that come in like pill form?
Yeah, it comes in pill form or in a granular form as well.
Mm-hmm. Well, we'll certainly have to look into that. I think
maybe we can start combining it with low-dose naltrexone.
Yes.
Low-dose naltrexone and magnesium together.
Have it as a
maybe we can get one of the pharmacies to compound that for us.
That's food for thought. I'll get back to you on that one. We have a question here from Lisa, and it's about allergies and fibromyalgia. She says, I stopped LDN for a few months, but again feel tired and cannot sleep. I wanted to start again, but at this moment in time I use melatonin. Can melatonin be taken with LDN, and can I start at 1.5?
Yes, both of those. Yes, LDN and melatonin can be taken together. You can also, take melatonin take LDN during the day if it's affecting your sleep. Like I said, initially, I think the majority of people have been using it at night because that's the original way in which it was described. But I think that a lot of physicians now realize that we can use it during the day. And in fact, depending on what your goals are for therapy, day use can sometimes be even more appropriate than night use, depending on what your goals are.
Mm-hmm.
The first time I took it, I had a nightmare. The second time I took it, I had the best dream. I mean, it was kind of more of an intense dream, but it was, worthy of a book. Linda, you could have written a book about this dream, and it would have been a bestseller. And the third night, I was so excited to get back to that dream, and nothing. So,
well,
it just depends.
I had no vivid dreams at all, so I feel I've been robbed of. Even though you had only one, you had one. I haven't had any.
I know, and I still talk about that dream, and I still try and recreate it, and I think in my spare time I need to write a book about that dream.
Melatonin is easy to get over the counter in the US, but we don't do that over here. But I don't like medication at all. And when I flew to Las Vegas for the conference, my body clock was completely upside down. It was an 8-hour time difference. And the first night I woke up at 3 o'clock in the morning, and I had to work. I had to see people, and I was on breakfast television on one of the television stations. And I think the next morning it was like 4 o'clock, and then the next day it was like 4:30, and I went into one of the local pharmacies, and the gentleman said, "How can I help you?" And I said, "Can you give me anything? I don't care what it is, anything, so I can sleep. I'm just so tired. I can't function." And he said I didn't need a drug, that I could actually have melatonin and to take it half an hour before I went to sleep, and to try and relax before, and not to get stressed that I wasn't going to sleep. But it worked. It worked really well.
Well, I think there's just like there is with prescription medications, there's this whole degree that really we should have to put medications, on this grading scale. One being a very benign medication, one that potentially has a much higher benefit to risk ratio, all the way up to 10, where those are the riskiest drugs, but yet the benefit is lower than the risk. And that way it would provide patients with an idea that not all pharmaceutical medication is bad, not all supplements are bad, but there's a whole grading system, and I think it would be very helpful, because I have a lot of people that are concerned about taking supplements on a daily basis, and I completely understand. I think as we age, melatonin is one of the hormones that really starts dropping off. There's a lot of good things that melatonin does. We have a way of measuring it. You can do a salivary measurement with people, and it's very helpful to get that sort of salivary measurement when people are waking in the middle of the night, to look at salivary cortisol and look at salivary melatonin. Before, who would drive in to get their blood drawn in the middle of the night? But by looking at salivary levels, we're able to see, what's going on in the middle of the night. And as people age, our melatonin levels do drop off. So I really feel like melatonin can be very useful in some people, and some people don't even realize. I mean, it can increase what we call the lower esophageal sphincter in the esophagus. So if people are having a lot of reflux at night, melatonin is helpful in decreasing reflux at night.
I used to have to take medication for reflux, but since I've changed my diet, that's another medication I've stopped. I don't need to take that anymore. So that was a really big plus. But I think people who can't sleep and then go to bed thinking, I've just taken my LDN and I'm not going to be able to sleep tonight because I didn't sleep last night, and get stressed about it.
Oh, yeah.
It's a cycle, isn't it, where you're thinking, I can't sleep, and that's on your mind when you lay down. And I think, you need, I don't know what techniques you tell people when they can't get to sleep. I used to do yoga, and I meditate, and I can put myself to sleep ordinarily that way, without having to take anything, but just by deep breathing and relaxation and that kind of thing. What do you recommend?
Yes. So I always, once again, I find out what the person's tried in the past. So I'm not, if they haven't tried anything, then yes, I do always start with, trying to learn something that you will have with you, whether you're traveling to Las Vegas or not. People can't just run out and go and get melatonin in the middle of, the night at 11 o'clock at night if they're in a, strange environment. So I think that having these sort of programs within our own body that we have at our disposal is by far and away the best way for us to put those plans into place. A lot of times what I'll have people do is try and associate some of the meditation techniques that you're talking about, counting backwards, starting at 100 and counting backwards by 3, and really focusing on the breath. Doing what we call 4-7-8 breathing technique, where you breathe in for 4, you hold for 7, you blow out to 8, where you're really kind of tying up the mind and trying to get your mind off of, I really need some sleep tonight. I can't believe this. I didn't sleep well last night, and now it's going to happen again. That sort of cycle that sometimes our brain gets into is very detrimental. And so the more that you can kind of tie up that aspect of the brain, those racing thoughts, those, I really should be asleep now, I've got this big radio interview tomorrow, those sort of things. And tying that in with relaxation. If people feel like that they still cannot sleep, then getting up, moving to a different room, and reading a very boring book. People even talk about trying to read a dictionary or something that you would find to be very boring, very mundane. Just, again, trying to get your mind on paying attention to something else instead of what you feel like you should be doing. And then once you start feeling a little bit fatigued, then you go right straight back and you lay back down and you stay in that quiet space. For some people, there's people that try all of these, self-regulation techniques, and they're still not sleeping well. And for those people that have tried all of those things, obviously we check hormones. I check melatonin levels. I check progesterone, estrogen, testosterone. I want to see specifically what people's sex hormones are doing, what their thyroid hormones are doing. And then we go from there and try and base, instead of me just basing it on guesses, I like to individualize the treatment for the patient based on specifically what sort of issues they're having. Obviously, the treatment for high cortisol at night, as somebody's going to sleep, is very different than somebody who has hormones that are barely detectable. And those people need, to consider hormone replacement, whether it be melatonin or progesterone, whatever.
And that leads me to another question we're frequently asked. Now, when I go abroad, I always take my LDN before I go to bed, regardless what time zone I'm in. And some people say that they are a night shift worker. Should they be taking LDN when they get up? Should they be taking it when they go to bed? Does it matter? How would you address that question?
Well, I address the question of we don't really know whether it matters or not. You have what I tell people is that we have to get to a point to where you're a responder. So that's my initial goal, is to start people on it, to get them to be a responder, not to say, well, you must be, that percentage of people that don't respond to LDN. How do we get you to be a responder to LDN? Once I know that you are responding to it, then I say, now we get to a chance to see if it makes a difference in you. Mm-hmm. Because it may not make a difference in you whether you're taking it at the same exact time every day or whether you're taking it right before bed, whatever time that is, whether it be 1 o'clock in the morning or 8 a.m. But you don't really know how that person until you get them to be a responder. But once they respond, then I think people will tell you that, yes, I found out. And these are people that are can be, and I think this is where journaling, like you were talking about, journaling can play a significant role. And there's the LDN app, as you know, which can be very, very helpful in helping people plot, the symptoms that they're having and what sort of symptom improvement that they're having. And but I tell people, don't get so hung up on having to take it before bed that you end up missing a dose, or, take it when you feel like that you're going to remember every single day to take it. Mm-hmm. And I like the idea of taking it before bed because I like to think about all of the hormones that are going through our brain and, increasing growth hormone and trying to optimize the brain to provide healing hormones to the rest of the body. But I find that if that is a stumbling block to somebody taking LDN, then I would much rather them be taking it at other times of the day than not taking it at all. Mm-hmm. And for some people, too, you can find out that the right dose, again, I've had some people that I've changed over to twice-a-day dosing if they weren't getting a good response with once-a-day dosing. Mm-hmm. So it varies from person to person, just like all of medicine.
Yeah. I'm going to have to stop you there. We have come to the end. I'm sure we could have gone on for another couple of hours. It's been a joy and a pleasure to talk to you. Now, for our listeners, if they would like to come and see you or book a consultation, how do they go about doing that?
Oh, they can just call the office or send me a quick email, and we can talk about scheduling that appointment, either in person or online or something.
We haven't yet told them where your office is and how to get hold of you.
Yeah, so our office is just north of Salt Lake City. It's in a city called Kaysville, Utah, and the office number is area code 801-882-2200. And the website is www.utahfunctionalmed.com.
Wonderful, and thank you very much for being with us today.
Thank you. Thank you for having me.
Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well. Today's show sponsor, Care First Specialty Pharmacy. They are leading compounders of LDN and other custom treatments servicing patients in over 18 states coast to coast. They are widely accredited to provide you with the highest quality demanded by the industry and the expert service you expect. To learn more, call 844-822-7379 or visit cfspharmacy.com.